Very good. Thank you for the introduction, and glad to be here virtually to present sort of an update on frontline management of diffuse large B-cell lymphoma and where we are in 2022 and where we're going. So as I'm sure everyone in the audience is very familiar, R-CHOP has been the sort of reigning champion for the last 20 years or so. And this, of course, is a multimodality treatment with monoclonal antibody, anthracycline, alkylating agent, vinca, and glucocorticoids. And together, this produces a durable response or cure in the majority of patients. Because not all patients are cured, there's always an interest in doing more. And this is sort of a view of a simple oncologist with a stethoscope here saying, you know, me like R-CHOP. And then there's always the question whether a bigger, stronger chemotherapy is better and a bigger stick. And so to do this, the EPOCH regimen has been widely studied. Instead of using R-CHOP, you now have an additional agent with etoposide, which is a topoisomerase inhibitor, of course, and you've added this not just as another drug, but as a continuous infusion and with dose escalation to reach higher doses and more anti-neoplastic effects. There was a randomized trial published in 2019 from the Alliance US Cooperative Group, which studied R-CHOP versus dose-adjusted EPOCH for 6 cycles. And unfortunately, there was really no improvement in either progression-free survival or overall survival in this study, suggesting that for standard risk patients, R-CHOP is no worse and EPOCH is no better. However, as I'm sure everyone in the audience is quite aware, diffuse large B-cell lymphoma is not a single disease, but is has a certain degree of clinical heterogeneity. Much of this can be accounted for by simple clinical factors that are sort of codified in the International Prognostic Index, or IPI, as well as double hit status. And I'm sure you've seen the IPI scores and the outcomes depending on your age, performance status, stage, LDH level, and number of extranodal sites. You may have a very favorable or a less favorable overall survival. In addition, it's been recently recognized over the past 10 years or so that double hit lymphoma with translocations of MYC and BCL2 primarily have much worse outcomes than standard non-double hit lymphoma. And this is a large retrospective review of the outcomes of double hit lymphoma patients treated with either R-CHOP, or on the top here, you can see more intensive induction regimens like dose-adjusted EPOCH or hyper-CBAT or others. And so the question really in 2022 is, should we use EPOCH, dose-adjusted EPOCH, or other intensive regimens for double hit lymphoma? And I would say in the United States, it is common. So if you have non-double hit lymphoma, the standard of care remains R-CHOP, or has remained R-CHOP. And if you have double hit lymphoma, which is really only about 10% of cases, our dose-adjusted EPOCH is frequently used, although other regimens may be employed. And so this is overall, you know, looking at lymphoma still as sort of one disease, or maybe two if you include double hit lymphoma. But we know now that biologic differences can impact the outcome. And this is seminal work that goes back again over the past 2 decades, which used gene expression profiling to demonstrate that diffuse large B-cell lymphoma that arises from a cell of origin in the germinal center actually has a much better outcome, as opposed to diffuse large B-cell lymphoma that arises from a cell of origin that represents an activated B-cell gene expression profile. And you can see in yellow here, the germinal center large B-cell lymphoma patients tend to have much better outcomes with standard R-CHOP therapy. And so if we go back to our sort of oncologist with a small, a small club, now we're sort of asking the question, well, he still likes R-CHOP. And now we have the translational scientists who are telling us that, we're very primitive and we need to move beyond just treating this as one disease. And so if we look at this sort of idea that there's at least two different types of diffuse large B-cell lymphoma, and the activated B-cell subtype has activation signals arising from NF-kappa B, we know that proteasome inhibitors are particularly active in inhibiting this function. And so there were studies, single-arm studies of bortezomib when added to R-CHOP, in which the bortezomib, which was given on days 1 and 4, was combined with R-CHOP. And in this single-arm study, if you then look back at the patients who had germinal center or what's called non-germinal center, which is an approximation for ABC DLBCL, you see actually that the non-germinal center patients had equivalent outcomes, again, in a single-arm study. So this led to 3 randomized trials, one called Pyramid, one called Remodel, and another one through the Spanish group, which were randomized trials of R-CHOP with or without bortezomib. And probably the largest trial is in the middle here of over 940 patients. This was conducted in the UK. This is called the Remodel trial, and this was published in 2019, in which all patients underwent full gene expression profiling. And if they had germinal center diffuse large B-cell lymphoma, they received R-CHOP or R-CHOP with bortezomib. And what you can see here is that there was really no improvement for those patients. In the activated B-cell patients, the red line is the addition of bortezomib. There was a trend, although not statistically significantly different, for the addition of bortezomib to these patients. And in the unclassified group, this outcome was no different. And so as a whole, this was viewed as a negative trial because despite enormous amount of effort and technical skill in getting patients assigned by gene expression profiling, the use of bortezomib did not improve the ABC DLBCL patients in a significant way. Since that time, there's been other trials. We'll summarize them on this slide, which is over the past 5 to 10 years, we had many attempts to improve on R-CHOP. The top trial here was called the Goya trial, which attempted to substitute obinutuzumab for rituximab and was a negative trial. I have the next one here, the Alliance trial we talked about, which is R-CHOP versus dose-adjusted R-EPOCH. And again, this is a negative trial. It may be that patient selection leading to a relatively favorable outcome, patients with favorable outcomes were enrolled, leading to better than expected outcomes with R-CHOP in this study. And then at the bottom, we have the Remodel trial. And since then, there's been at least 2 other studies, including the Phoenix trial and 2 randomized trials with or without lenalidomide, which attempted to enroll patients with non-germinal center or ABC diffuse large B-cell lymphoma by gene expression profiling. And all of these trials, unfortunately, were negative. And so we've been left with the possibility that we may be sort of targeting the wrong patients with these drugs, and that maybe we need to be more precise in our approach. In the meantime, there has been significant interest in the use of antibody drug conjugates for the treatment of B-cell malignancies. In particular, polatuzumab vedotin is an antibody drug conjugate with a monomethyl ester E drug linked to an anti-CD79B monoclonal antibody. And as is common with all of these antibody drug conjugates, the antibody drug conjugate is internalized intracellularly, and this then leads to release of the cytotoxic agent, which has antitubule properties. This drug has significant single agent clinical activity far beyond just CD79 targeted monoclonal antibody without drug linked. And so this agent was tested in relapsed diffuse large B-cell lymphoma patients. This is a small randomized phase 2 trial in which bendamustine rituximab was given alone or in combination with polatuzumab vedotin. And as you can see on the right, there was a significant improvement in the progression-free survival by the addition of polatuzumab, with a median progression-free survival approaching 10 months as opposed to approximately 4 months with chemotherapy alone. And interestingly, this translated into an overall survival advantage as well, with the suggestion of a possible plateau on the curve, although longer follow-up would be needed. And again, these are relapsed patients. Somewhat provocatively, when we examine the subgroups of those with germinal center or ABC patients, as you can see, the numbers here are pretty small, but there seems to be a slight improvement in the response rates, at least the complete remission rates in the ABC patients. And if you look at the PFS, actually, the difference between BR with or without polatuzumab is non-existent for patients with germinal center diffuse large B-cell lymphoma. But on the bottom here, if you examine the outcomes of the, the top is ABC versus GC, and the bottom is ABC versus GC. And so the top is bendamustine rituximab, and the bottom is bendamustine rituximab with polatuzumab. And so what you can see is that there seems to be the suggestion of an improved outcome in the higher risk ABC patients by addition of polatuzumab. So this sort of set the stage for what was called the POLARIX trial. This is, again, going back to what we call backbone of R-CHOP chemotherapy. By eliminating vinca alkaloid and substituting polatuzumab vedotin, you have the potential for higher concentrations of delivery of anti-tubule drug intracellularly. And so this POLARIX trial was a large international study of over 800 patients with treatment-naive diffuse large B-cell lymphoma. I'd like to highlight that the international prognostic score was 2 to 5. So low-risk patients were intentionally not enrolled, which provided the opportunity to perhaps see more signal of activity. This is a randomized study of R-CHOP versus R-CHOP with polatuzumab. And if you examine the baseline characteristics of the patients who are enrolled, the majority of the patients in both arms had advanced stage disease. And actually, the majority of patients had IPI scores of 3 to 5. There were about 30% of patients with activated B-cell subtype diffuse large B-cell lymphoma, and a relatively small number of patients with double or triple hit lymphoma. The adverse events in the outcomes of the patients are shown here. So there was some peripheral neuropathy, about half of the patients in both arms. But remember, in R-CHOP, you get peripheral neuropathy from vincristine, and a very small number have grade 3 or 4 peripheral neuropathy. Although you don't have vincristine in the polatuzumab containing arm, polatuzumab vedotin can cause neuropathy. And so you did see about half the patients, but these were not statistically or meaningfully different in the R-CHOP arm. Neutropenia was well balanced in both arms. The rates of febrile neutropenia were comparable. And if you look at the efficacy of this regimen, the addition of polatuzumab, or substitution, I should say, for vincristine in the R-CHOP backbone, led to a statistically significant improvement in the progression-free survival to 76% at 2 years from 70%. This was a p-value of 0.02. So if you sort of do a calculation where you ask the question, how many patients are needed to prevent one relapse, the number needed to treat is 16. There's no difference in overall survival in the treatment arms, suggesting that among those who relapse after R-CHOP, there are sufficient salvage regimens to achieve a similar overall survival. subgroup analysis of the study is very interesting. There seems to be a higher benefit for the higher risk IPI patients. Those are with IPI scores of 3 to 5. And those patients who had non-bulky disease had more benefit. Particularly interesting and thought-provoking is the potential for a differential impact of cell of origin on the outcomes. Historically, you'll see in the R-CHOP arm that patients with ABC subtype have inferior outcomes, but there was an inversion of the outcomes such that the ABC patients actually had superior, numerically at least, 2-year progression-free survival of 84%, which is much higher than is seen with R-CHOP. There were not really enough patients with double hit or triple hit lymphoma to conclude whether there's benefit or not of this regimen. What were the treatments that patients received after polatuzumab or with RCHP versus R-CHOP? Well, those are shown here. And the numbers indicate that 99 patients who were started with polatuzumab required at least one subsequent anti-lymphoma treatment, whereas 133 of those assigned to R-CHOP required subsequent therapy. These include systemic treatments, stem cell transplant, and CAR T-cell therapy. So this is a primitive calculation. I've called it a back, we take an envelope and write some numbers down. And the question is, of course, about cost. So in US dollars, what is the cost to prevent one relapse? And we know that due to salvage treatment, there was really no overall survival advantage between the two arms. So if we simply tally up the costs for care and with available data, this is a very simple calculation. You can look at the cost of the polatuzumab. In the polatuzumab arm would be about $35 million. But there are more stem cell transplants in the patients who started with R-CHOP, and a rough cost of each transplant might be $100,000. CAR T-cell therapy is about $500,000 per patient. And so, you know, we get a total where there is a pretty significant imbalance with a higher cost. And so at least by this calculation, you might say that it might cost about $1 million to prevent one relapse, which is a pretty high price tag and maybe calls into question the pharmacoeconomics of this, applying this treatment to all patients. So let's kind of look a little bit more towards the future and move past just treating all patients the same. As is probably familiar to the audience, there's been an explosion of next generation sequencing and other molecular techniques to query the molecular features of diffuse large B-cell lymphoma as well as other malignancies. This is the first paper published from investigators at Duke University Medical Center, which described the frequency of mutations across 1,000 patients with diffuse large B-cell lymphoma. Interestingly enough, it was noted early on that there was a differential sort of frequency of some of these mutations in patients with activated B-cell versus germinal center. In particular, the mutation in EZH2 was more commonly found in germinal center patients, whereas mutations in MYD88 and CD79B are more common in activated B-cell patients. Beyond this paper, there's now been 2 more integrated multi-omics studies. This is seminal work by investigators at the Dana-Farber Cancer Institute, led by Dr. Margaret Shep. And in this study, there was not only mutation analysis, but gene expression profiling and copy number alteration assessment to describe what's called clusters. You can see cluster 1, cluster 2, 3, 4, and 5 that all have some degree of similarity, molecular similarity. And what was noted actually is that the clinical outcomes of patients with germinal center diffuse large B-cell lymphoma can be subdivided into cluster 3, having higher risk disease than cluster 4. And similarly with ABC subtype, we can see that there's actually a favorable risk, which has the profile of cluster 1, whereas cluster 5 tends to have more unfavorable outcomes. And cluster 2 is also sort of a high-risk group of patients. This work was also largely mirrored by work through the National Cancer Institute, the NIH, led by Dr. Lou Stout. And similarly, this group described multiple groups with different nomenclature that have different clusters. What you can see is, again, in patients with germinal center diffuse large B-cell lymphoma, there are worse outcomes in those with the so-called EZB subtype. And in patients with activated B-cell subtype, we can see poor outcomes in the group called MCD, and other ABC subtypes have better outcomes. So if you're sitting there and worrying about the future and wondering how these all fit together, this might look, so how you view this. But it is reassuring to know that the work by Chapuis and Ship is actually very similar to the findings of the independent studies initially published by the Stout group. So cluster 4 has the mutation profiling listed here and a better clinical outcome. And this is similar to the group called ST2. Similarly, the third cluster is high-risk germinal center patients with these EZH2 mutations and BCL2 translocations. And then if you go down to the activated B-cell subtype, we know now that cluster 1 tends to have better outcomes, whereas cluster 5 mirrors the poor outcomes of this MCD subgroup that has mutations in genes in the B-cell receptor signaling pathway. And then finally, cluster 2 is characterized by inactivation of the p53 gene, and these patients tend to have relatively sort of intermediate prognosis. So if we look toward the future, what has been put forth is the idea that not only is diffuse large B-cell lymphoma categorized as ABC or germinal center, but you could actually imagine a scenario in which a tumor biopsy is classified by using this algorithm called LymphGen. And then based on the subtype, you would then target individual pathways with specific pathway inhibitors such that the genetic subtype could aid in the development of rationally targeted therapy. This idea has some justification for it when examining the outcomes of patients on the Phoenix trial, which was the study of R-CHOP with or without the BTK inhibitor ibrutinib. Interestingly enough, you can see very favorable outcomes in the red lines here in those MCD patients. Those are the high-risk activated B-cell patients when treated with R-CHOP with a BTK inhibitor. And so one of the concepts that's being developed in the U.S. cooperative groups is a lymphomatch trial in which we have molecular subtyping applied to biopsies from a large number of patients with diffuse large B-cell lymphoma. And depending on their cluster, they would ultimately be randomized to receive standard of care chemotherapy, which could be R-CHOP or R-CHP with polatuzumab, depending on various factors, and then adding various pathway inhibitors to test the selective benefit, if any, of adding these pathway inhibitors to standard treatment. So I'll summarize by saying that diffuse large B-cell lymphoma is not a single entity, but is unfortunately still largely approached this way clinically in 2022. While in general, germinal center-derived tumors have more favorable outcomes than those with activated B-cell subtype, there is definitely additional heterogeneity that can be explained. And we mentioned this cluster 3 or EZB subtype has inferior outcomes in the germinal center subtype. The MCD or cluster 5 has inferior outcomes in ABC subtype. And TP53 mutation is a negative prognostic indicator in all cells of origin. Clinical trials of targeted pathway inhibitors in large patient populations have largely been unsuccessful, but until recently, when the addition of the anti-CD79 antibody drug conjugate, polatuzumab vedotin, was used to substitute for vincristine in the R-CHOP backbone. And for patients with IPI scores of 2 to 5, we saw comparable toxicity with progression-free survival advantage without a overall survival difference. 2 randomized trials have suggested that ABC tumors may be more sensitive to polatuzumab, but it's really unclear if polatuzumab with RCHP is beneficial for double-hit lymphoma, or whether something like dose-adjusted EPOCH should remain the de facto standard. More sophisticated cost analysis than what I put forth is really needed to determine the cost effectiveness of uniform use of polatuzumab in the frontline setting. And in the future, frontline clinical trials will really require integration of multi-omic biomarkers to test precision medicine using specific pathway inhibitors for individual subtypes of diffuse large B-cell lymphoma. So with that, I'll conclude and thank you for your attention and take questions if there are any.